morning and welcome. My name is Amanda Bassett, and I'm the Chief Advancement and External Relations Officer at the UNM School of Medicine. I am beyond thrilled to see so many of you here tonight. We truly appreciate you braving the rain to be here with us, as we know it may have been a challenge for some of you. I would like to take a moment to give a special thanks to the Albuquerque Academy for hosting us and supporting us during our lecture series. I'd also like to give a special thanks to the City of Albuquerque, who continuously records these so we can share them with people who are unable to attend. We started our community lecture series in the fall of 2015, and that following spring we had our first Dazzling Brain lecture. We established these presentations to reach beyond the university campus and bring valuable, useful, and most importantly, accessible knowledge to you, the community that we serve. The Dazzling Brain Lectures are part of Brain Awareness Week, a global campaign and celebration to increase public awareness about the progress and importance of brain research to us all. Our topic tonight, pain, touches nearly everyone in this room. Whether you yourself suffer from chronic pain or somebody close to you does. Let's get a feel for the room tonight. How many of you suffer from chronic pain? Raise your hand. Wow. How many of you have a loved one or know someone who suffers from chronic pain? I think we got everybody right there. As you can see, we are all in this together, and we all know living with pain can be a challenge. Tonight, we have 3 short talks that are woven together to take us from fundamental research through what pain means to us personally and to our families and our friends. Our goal this evening is to change the way we all think about pain and the way it is treated. Our speakers will focus on understanding how your dazzling brain responds to and can work around chronic pain. First, Erin Milligan, Associate Professor in the UNM Department of Neurosciences, will explore what pain is and some of the ways it works and doesn't, and how it spreads through the body. She'll also discuss some exciting new research that may impact the way we treat pain. Brian Shelley from the UNM Pain Center and professor in the Department of Family and Community Medicine will take us on a journey through the reality of chronic pain and how it can impact our lives. He'll also provide more clarity on some of the emotional consequences of pain and why they are very real to all of us. And lastly, Evan Rivers, UNM Chief of the Division of Physical Medicine and Rehabilitation and Associate Professor in the Department of Neurosurgery, will focus on the various treatments for pain and how you and those you care for and about can manage your pain while still leading a fulfilling life. We'll conclude the evening with a question and answer session. As soon as the presentations are over, 2 of our staff will walk up and down the aisles, collecting your questions on the note cards provided. Our moderator for the question and answer session is Joanna Katzman, who served as the director of the UNM Pain Center from 2011 through 2018. She is the Senior Associate Director for Project ECHO and professor in the Department of Neurosurgery. So, with that, without further ado, I would like to welcome Erin to the stage.
So thank you so much for coming out this evening. It's really a pleasure to be able to be here and talk to you about this very important topic. So I want to start by asking you a question, and that question is, can you remember the last time that you touched something really, really hot? Do you remember what that felt like? Well, I do. The last time I felt something really hot, I was boiling water to make some delicious tea for myself, and I ran over and grabbed that tea kettle, and I picked it up, and before I knew it, that kettle was out of my hand, and it was on its way down to the kitchen floor. And then I realized that really hurt. So it seems like, stepping back from this picture, that my body seemed to react to that hot tea kettle handle before I actually realized that I made a mistake. So what happened here? What did my body actually do? Well, it turns out that our bodies are filled with nerve fibers that course through our bodies. It includes our skin and our muscles and our joints. And they make their way all the way up the spinal cord. And they synapse onto special neurons there in the spinal cord and relay that information on up to the brain. But what I want to do right now is to pause and consider the spine and the spinal cord. Now, we know what the spine is. It's actually a stack of lots of little bones that are stacked on top of each other. And we know these bones, we call them vertebrae. And if we were to look right in the center of those vertebrae, we'd see there's a hole in them. So if we stack these little vertebral bones one on top of each other, we would create this kind of tube-like canal that extends from one end of the spine all the way down to the other. And it's within this tube-like canal that our spinal cord lives. And it's our spinal cord that's responsible for receiving all of that information from our nerves in the body. So let's return to this image here and think about those nerves that reacted to that hot tea kettle handle. What actually happened? What it turns out is that these nerves are designed to be exquisitely sensitive to this very intense heat or very intense pressure pains. And what's amazing about these nerves is that they only activate on this very intense information that is being sent to the spinal cord. And it's important to know that there are different kinds of nerves that relay gentle warming and gentle cooling and gentle touch. And those gentle nerves are really important because they help us to interact with our environment and to understand our environment. And what that means is it helps us to know the shapes of objects. For example, the shape of a ball or the shape of a box or the smoothness of your computer screen or the roughness of your carpet. And so what's so fascinating is that when we return to this and think about those nerves that are exquisitely sensitive to this extraordinary intense information, this hot pain and hard pressure pains, think of whacking your thumb with a hammer by accident because you missed the nail. And so what happened in this instance to me is that those nerves that respond like this are called pain fibers. And those pain fibers within milliseconds relay this information to the spinal cord. And then that's what happened. It triggered this let go reflex, let go of that hot kettle handle. The important point here is that my brain didn't do that work. My spinal cord took this information and it did the work. It made me reflex and let go of that. It triggered this reflexive let go response. And so what's really important here to consider at this point is that these pain nerves are amazing. They relay this information really fast at about 20 yards per second. And they do all of this to protect me from any further damage. That's really cool. No pun intended, actually. But what wasn't cool is what followed. So what followed was that my hand turned red and a different kind of pain started to emerge. It was like an aching pain, a diffuse pain, a poorly localized pain. And in fact, it was like glowing hotter over time. And in fact, it even started to affect areas of my finger and my hands that didn't directly contact that hot kettle handle. So this kind of pain that occurs, it made me, as the pain waxed and waned through the rest of the afternoon, I stopped using my hand. I iced my hand. I changed my behavior so that I could heal. And so my point here is that our pain fibers, both of them, those fast pain fibers that trigger that reflex to let go, and those slower pain fibers that trigger this change in behavior so that I can stop using my hands so I can heal, they're doing what they're designed to do. They're doing their job. And what I mean by that is our pain fibers are meant to protect us, to keep us healthy, so that if I have a hurt, I can stop using my hand so that I can heal, so that I can resume a normal life again. What my pain fibers also do is they teach me a lesson. Don't do that again in the future. Don't pick up a hot tea kettle without the pot holder. Now, I looked at people who raised their hands, and I know there are many of us who are directly affected or who know somebody where this pain didn't simply go away. And this is true, it's very scary because it turns out that there are scientists and doctors for a number of years now, decades now, who have struggled to try to understand why is it that these pain fibers refuse to behave the way they were originally designed to behave? And it makes these pains very difficult to treat. In fact, it turns out that there is very, very powerful changes that occur in the spinal cord. That's right, where those pain fibers are relaying their information, their signals, that information about hot and hard pressure pains. In other words, pain signaling in the spinal cord is a highly dynamic process. That means those signals change in the spinal cord, and those changed signals end up making their way to the brain. So what that means, and we actually see this in people who experience chronic pain, and that is that in some cases their pain is actually amplified. What that means is that that hot that I was telling you about is now experienced by people who have chronic pain as extremely hot. And we call that hyperalgesia. It's from the Greek word algesia, which means pain sensitivity. We know of analgesia as the lack of pain. And so hyperalgesia is exaggerated pain sensitivity. Another kind of problem that people with chronic pain experience, and it's very, very serious, is when it has to do with those gentle fibers that I was telling you about that relay gentle information, gentle touch, gentle warming. And what happens is that as these fibers are trying to relay their gentle information all the way up to the brain, they get hijacked in the spinal cord. And what happens is that now this gentle information is miscoded as very painful. That means gentle touch feels like a burning, lancinating pain. This is a very serious problem for pain patients and chronic pain patients because simply putting on your clothes can now become very, very painful. And so we have known now for years that because of this pain that travels to the brain, it's very difficult to understand. It's difficult to explain. And I know that there are some of us here that know they've heard this expression, that pain, it doesn't make sense. It's in your head. It can't be real. It's in your head. Well, now you can say, yeah, you're right. It is in my head. And here's an example. Now, what you're looking at here is a side of the brain. It's an MRI image of the side of the brain taken in two different places. And what we're seeing on this left panel here is the far side of the brain that includes part of the cerebral cortex that is really important for understanding and coding events that occur around us, to put meaning to these events that occur around us. And this right panel is the side of the brain that's taken straight down the middle, so that we can look at some really interesting deeper structures. And what we're seeing here in this image is a portion of these deeper structures actually here that are important for emotion. Now, this person has experienced stable chronic pain for a year and a half following a spinal cord injury. Imagine that. And what I want to point out at this point is that if we were to image a healthy brain from an individual and then stimulated their hand with a pinprick pain, what you would see is a different region that would light up in the brain somewhere around here, and that region is called the primary somatosensory cortex. That's important because when that region lights up, that means it's telling us exactly where that pain is and how hot or how bad that pain is, like I had experienced when I picked up that tea kettle handle. But what is striking about this data is that this individual is undergoing MRI image under basal conditions. There's no stimulating, precipitating event that's creating these signals to occur in the brain. What that means is that this person is now coding their chronic pain in a way that means something. This chronic pain has meaning to this person. And it's not simply in the primary somatosensory cortex anymore, but it's extending to regions that are important for telling us what do these things mean to us. And when we look at this region, this is very important. This is a region that is called the Anterior Cingulate cortex, and this is important for emotion. Think about anxiety. Think about depression. Think about anticipation. This person is coding that chronic pain. It now has an emotional, it means something, it feels something. So here, in this region and in this region, this individual is now telling, it has pain that's coded that means something and it feels something. This is the dorsolateral medial prefrontal cortex. And so I also told you that pain is highly dynamic in the spinal cord. Well, just like the spinal cord, pain is also very, very dynamic in the brain. What that means is that pain can change over time, and we know that's true because it's not just the primary somatosensory cortex that's activated, that we're seeing activated. It's regions that code pain with meaning and with feeling. Now, what's really interesting here is the possibility that maybe we can change these areas in the brain that code pain if we change how we think about and how we feel about that pain. We're going to hear a little bit more about that from my colleagues, Brian and Evan, in just a little bit. Now, up to this point, I've talked to you about neurons and how they're important in relaying pain. But I want to tell you about a different kind of cell. It's a very interesting cell, and this cell is called a glial cell. And what you're looking at here is an astrocyte. And this astrocyte, it's beautiful. It has all of these long processes that extend in all these different directions. And you can see that they have the potential of interacting with many different neurons in the spinal cord and in the brain. Think about those pain neurons. I'm really excited about these glial cells because this is what I do research on in my laboratory at UNM here. And what we're learning is that these glial cells get all excited and jazzed up under chronic pain conditions. And these glial cells can impact how neurons behave. And we've learned that if we learn that these glial cells are important in that kind of pain that I told you about that creates hyperalgesia. And they're important in that kind of pain that miscodes gentle touch as very painful. And what we're learning now is that if we target these glial cells, we can prevent hyperalgesia. We can prevent the miscoding of that light touch into pain. We can target these glial cells while not targeting the neurons, leaving the neurons alone. So they remain unaltered. And that's important to consider because currently available pain drugs often have unintended side effects that affect neuronal function as well. And so this is really exciting because if we target these glial cells, what that means is that we might be able to come up with new pain therapeutics that leave the neurons totally unaltered. And that means that we might be able to then control the pain, calm those glial cells down, thereby calming the neuron so that pain fades away and it never returns, so that we can resume a normal and healthy life. Thank you for your attention.
Good evening. Great to see all of you come out to hear about this very important topic. I want to start by thanking my partner in crime this week, Erin Milligan, for her exciting talk about pain and how it spreads from the finger to the spinal cord and up to the brain through nerves you've heard about and maybe a kind of cell you hadn't heard about until tonight, the glial cell. What I'd like to do tonight is talk about how pain continues to spread, not just through the nervous system, but to other parts of the body, to the psyche, and how pain spreads into all parts of people's lives, and why that's important. Chronic pain, up till tonight, has been defined as pain which continues after tissue healing. And I'm going to submit to you that this definition is outdated, because if we have an injury and tissue heals, this definition assumes that everything stops right there, and the pain makes no sense. And what you'll see tonight, I think, from the three presentations is there's so much going on at the physical level and psychological level, both of which are real, which explains this chronic pain experience, which is more than just pain. People often ask why I, as a family doctor, treat people with chronic pain exclusively. And I started as a family doctor. I did residency here at the University of New Mexico in the late 90s. And I remember my first day in clinic quite well when I inherited several patients on large doses of opioids. This was the late 90s, and the opioid epidemic was in full swing. I just didn't know it until I got to residency. And I was an obedient intern, more obedient than I am now, I think, and refilled these medicines. I was told to. Oh, that's just what we do. And over the years, the months and years, I wanted to know more about this. I wasn't satisfied just refilling opioid prescriptions, and I wanted to teach myself more about diagnosing and treating pain, and so I did. And now I work at the pain clinic. But those are opioids. Lest I sound too pious about this, I had my own pain issues as well. I'm not saying I have chronic pain, but I used to get episodes of very severe back pain. This was usually after doing something very strenuous, but the last time it happened, it was not exactly strenuous. I temporarily disabled myself trying to get out of one of these. Yes, this Adirondack chair tried to kill me. But seriously, it seems silly now, but I remember so vividly having the pain and all these other associated thoughts. What is this? What's wrong with my back? What if it doesn't go away? What if I can't play with my girl? And what if I can't do my work? And does this mean I can't ever live in the Adirondack? But seriously, just for this episode of back strain, these anxious and depressing thoughts came right away. All centered around this idea of, well, what if this doesn't go away? So imagine the thoughts and feelings you'd have, or maybe you've had, when you realize the pain isn't going away, and how disabling that might be. In fact, now we have very solid evidence that pain and depression are intertwined and feed on each other. And I see a lot of people nodding their heads. You don't need medical literature to tell you that. But I say this because I think there's a notion out there that we should just put up with pain. People with chronic pain should just suck it up, stiff upper lip. And some people can do this, whether it's naturally or they make great effort to do it and they succeed. But many patients, I'd say most patients with chronic pain, aren't so lucky. And there are many reasons for this, and I'd like to go through some of these. We've already seen some pictures of the brain. This is my brain, that's why it's fuzzy. And when we look at these side cuts, it's as if you're cut down the middle and we're looking at the side. You see multiple areas. This is where you feel the pain, where the brain can say, oh, that's the finger or that's the toe. But we see other areas light up that have to do with the emotionality of this, how the pain is interpreted and experienced, and how we think about it. And we can show this now with MRIs that show blood flow to the area. You have more blood flow when you have pain. What's reassuring is you have more blood flow to these areas as well when you do relaxation and other things that seem to help pain. We've learned from Erin about the anatomy of how pain travels through the body and spreads through the nervous system. We've heard about how pain is experienced emotionally and how it affects thoughts, cognitions. We can see that and we can describe it. But we also know it from hearing the stories of our patients with chronic pain. We knew that long before we had such pretty pictures. How people describe how pain starts to affect all parts of their lives and brings them down. People with chronic pain often can't do the things they're used to doing or that they want to do. And this is more devastating than you think. If you have pain, you know what I'm talking about. And I say this because there's another notion out there that if you have pain, well, you just get a different job. Or you just do your chores differently, or you get some help, or you just somehow fix the situation. That's not so easy, is it? Think about what would happen to you if you couldn't do the work you're used to doing, or used to do. Work that you may have done for decades. How would that feel? What would you think about yourself? Work is one of the ways we feel needed and important, and chronic pain can take that away, can take away our identity. Pain is depressing. But how does that happen? Well, it hurts. But we begin to think differently, and that can lead to depression. Negative thoughts can make us feel negative. And this is a very common experience in people with chronic pain. We talk about the thoughts related to depression as cognitions, and we also look at the behaviors. People with pain do less and might do things to protect themselves. And so we have cognitive and behavioral, and maybe you've heard of cognitive behavioral therapy. That's what this targets. Depression's more than a feeling. It's thoughts and behaviors as well. So if you're a truck driver, driven a truck for 30 or 40 years, and you hurt your back, and you can't drive anymore. Driving's hard work, and there's a lot of lifting around the truck. This takes away, the truck driver doesn't say, well, maybe I'll just learn how to write code now. That's not how it works. What's the truck driver's identity? Truck driver. And if that is taken away, it's gone. This is how the truck driver sees himself. It's how he contributes to society and to his family. That's taken away, he doesn't feel the same. He might feel like he's a burden to his family. He might feel like he's boring his friends. And he might become withdrawn and isolated. And even if he's not a burden, and even if he's not boring, it doesn't matter. If he thinks that is happening, then it's true for him. Those thoughts become fact. And when those negative thoughts become facts, we have another problem. Freud, who was not a truck driver, said, among many things, all we have in terms of meaning in life is love and work. And chronic pain can take away both of those things. We'll come back to that. We talked about how chronic pain can spread through the nervous system and from one part of the body to another. Perhaps you've heard of, or perhaps you have, a condition known as complex regional pain syndrome. It's a devastating injury to nerves, usually in one arm or leg. But we see patients for whom it starts in one arm and spreads to the other, or starts in the legs and spreads to the arm. This is devastating. You've heard of, or perhaps have, or know somebody who has fibromyalgia, widespread pain, which seems to affect various nerve pathways in the body, possibly including the glial cells that Aaron told us about. We know pain can spread within the nervous system. Pain can also spread from the nervous system or one part of the body to another. I treat people with muscle pain mostly, and most of the people with muscle pain that I see also have joint pain in the same area. So joint pain, in a way, can spread to the muscles. Nerve pain can spread to the muscles. So we see it go from one organ system to the other. Chronic pain is depressing in another way. When people with chronic pain seek to treat their pain, they realize the pills and the treatments are only so useful for most people. Some people do quite well, and Evan's going to talk about it. But for a lot of people, the news that our chronic pain treatments just aren't that good is depressing. Some people do take treatment and do well. But if people take non-steroidal anti-inflammatory drugs for long periods of time, they often have side effects like gastrointestinal pain. And even if they don't have those side effects and they take the medicine and it helps their pain, they live with the specter of increased heart attack and stroke from these drugs. Other risks from NSAIDs include damage to the, what is it? All right, just wanted to see if you're still with me. We have other medications, lots of other medications for chronic pain. A lot of them target the nerves. Others target muscles. And they have their benefits and limitations and side effects as well. But I really feel like we have to talk about opioids here. Now, opioids help people in the short term. They're the most effective painkiller we have. Absolutely. But for chronic pain, they become problematic. Not for everybody, but for a lot of people. We know about the problem in the United States with addiction and deaths from overdose, but most people who take opioids are not addicts. And most people who take opioids do not die. Instead, they live with taking opioids every day, for better and for worse. Opioids have a lot of side effects. Itchy skin is one, nausea, vomiting, constipation, sedation, making you sleepy, affecting cognition, affecting thinking. But did you know that long-term use of opioids can actually make your pain worse? We call this opioid-induced hyperalgesia, to use a word you heard from Aaron. The opioids make people more sensitive to pain. This is not well understood, but we think it has something to do with interactions between neurons, like the ones Aaron showed us, and also between the gut and the nervous system through our friends, the glial cell. And so taking opioids affects the gut affects glial cells affect the nervous system, and change our sensitivity to pain. Did you know, that's the gut-brain connection, did you know that long-acting opioids, not opioids that work right away and then fade quickly within an hour or two or three, but the ones that last for 12 hours, lead to higher rates of infection? That's an infection. The medical talk. I had to show something gross, right? Opioids suppress the immune system. You see, it's tough to take opioids. It's fraught with all these problems. Opioids can also shut down the gonad. And I didn't use a disgusting slide here. But I used a low energy light bulb because when our gonads are affected, we have lower testosterone, lower energy, less libido. You can see how this will affect someone's life and intimate relationship. This is real. So we see how chronic pain and its treatment can affect the body as well as the psyche. Make no mistake, this effect on the psyche is real. People really do develop these thoughts. They become isolated. They think they're a burden. They think they can't do things they used to, and sometimes that's true, sometimes it's not. These negative thoughts lead to negative feeling. And it's bidirectional. People with chronic pain are more likely to have or develop depression, and depressed people are more likely to develop chronic pain or experience it more severely. We come with this great ability to inhibit pain. There are parts of our spinal cord that are devoted to suppressing pain. However, depression, and I think some of the medications, interfere with that and inhibit the inhibition, the double negative. So if we normally inhibit it, that's good, and we take that away, that's bad. And so our own innate ability to deal with pain gets hijacked. Pain, insomnia, depression, these are all connected. We know they are connected through anatomic structures. We know they're connected through neurotransmitters like dopamine, norepinephrine, and serotonin, where some of our other medications work. Depression even affects the joints themselves. People with rheumatoid arthritis will have worse disease if they're also depressed. Like the joints know. So people with pain and depression will begin to avoid doing things that make their pain worse. They will avoid ordinary activities. They will shut down a bit. They might gain weight. They might become deconditioned, more prone to further injury and other diseases. They become afraid to move in the worst case scenario. And we call this kinesiophobia. Kinesio means motion, phobia means fear. Kinesiophobia means afraid to move because you think you're going to do damage or cause more pain. And this becomes a separate problem from the pain itself. It's related, but then it becomes its own problem and obstacle to recovery. Because we know we want people to move, but if they're afraid to, they won't. People with pain also become isolated. Like I was mentioning, they might withdraw from family and friends, thinking they're a burden or thinking nobody wants to hear about my problems. And depression can do that too. Depression just leads to social isolation. Employers might be helpful and accommodating at first, but might not be able to sustain that. And people often lose their jobs and their home all isolated. People with chronic pain become very worried about experiencing more pain in the future. They think if they reactivate their pain, it's going to be terrible. And in the worst cases, they think they'll induce this catastrophe. And we call this catastrophization. This idea that something terrible is going to happen if I move or if I get more pain. And that becomes a hindrance. That becomes an issue related to but separate from the pain, if you follow. So there's this downward spiral for some people. Pain leading to depression, leading to not moving as much and being afraid of more pain, etc. Pretty hopeless, right? Well, no. This is the way we have a downward spiral. We can make that spiral go up as well. We can deal with pain. We can also deal with and treat effectively kinesiophobia and catastrophization. And my other partner in crime, Evan Rivers, is going to talk about how this can be done. So I thank you for your attention, and I'd like you to give a warm welcome to Evan Rivers.
Good evening, everyone. Thank you so much, Aaron and Brian, for sharing the stage with me and setting it all up so well. It's been wonderful to work over the past few weeks and months with these folks. They've done so much for me personally in the past few weeks, but they also have committed their lives to helping people with pain, which is something I feel strongly about too. Now, I'm a PM&R physician, and I care deeply about people's lifestyles, about what they're able to do and how they're able to do it. And there were a couple things I wanted to go back over that we heard from Aaron and from Brian. The first one is that pain is useful. It means you get to drop the tea kettle before it hurts you too bad. And it means you don't pick up that tea kettle until you're good and healed. But we also heard Brian say that sometimes it doesn't heal up like we think it did. And what he was getting at there is that sometimes not doing things is actually hurting your healing process. So for a while, you have to be guarded, you have to be careful so that your body can heal up. But if you do that for too long, you lose too much of your life. It keeps you from being you. Did you guys know that pain is the leading cause of medical expenses in the world? And it's not just medical expenses, it's also the decrease in productivity. People who stop working because of pain aren't paying taxes, aren't supporting their family, and have to get support some other way. Really expensive. And it's damaging to people's souls. When people come to the doctor, generally it's after they've already had the chance to heal. And it didn't work out right. And when you go to the doctor, this is what you see. A pain scale. In case you needed some help understanding this, the left side of the scale means you don't have any pain at all, and as you go over toward the right side of the scale, you're saying, I hurt a medium amount, and then you're saying, I hurt really bad. And for the record, 10 is as bad as it gets. It doesn't get higher than 10. 10 is the worst. And that helps us, in a real snapshot, figure out kind of where people are at. And it helps us make decisions. So in my training, I really identified with what Brian was saying. You know, there were these patients that I saw and I was trying to treat with medications or procedures or things like that. And almost everybody was a 7. And 7's hard, right? That's severe and it's a big deal. And so we would try to do things for people. We'd give them opioid medications or we'd do an injection and we'd come back and they'd say, I'm better, doc. And I'm like, great. And I'm expecting that something like that's going to happen and it's a 7. And then we say, okay, well, it's still a 7, so we'll do something else. We'll give you a new medication. We'll give you a new procedure. And they come back and they said, you know what, that helped a little, doctor. So I'm thinking, okay, here. But no, it was still a 7. And then next time they'd show up and they'd be like happy talking about their grandkids. I'd be like, hey, so great, what's your pain? And 7. And then they would come back some other time and they'd be writhing in discomfort and they'd just be miserable and 7. And so I kind of, what I'm trying to get at here is that this number It doesn't include all the things that we feel, and it doesn't help express what's going on. But it is the place that doctors start. And our most effective treatments are the ones that take away all of the ideas of suffering and all the ideas of depression, all the ideas of limited behavior that we talked about before, and we just treat a thing in the body and then let everything sort itself out. I'm going to spend some time talking about those things. So this is a picture that was drawn by Rene Descartes, and he was around in the 1600s, and he was a mathematician and a philosopher, and he liked to think about really interesting things. And in this case, he was talking about where he dropped a tea kettle on the other side of this fire. And it had to do with burning something and sending that signal up the nerves and into the spinal cord, into the brain. And you can see this is not a sophisticated representation like Aaron showed you. This is rather rudimentary, but the idea is still the same. And when doctors do our treatments, we will tend to focus on helping a tissue heal, or we'll focus on treating a nerve, or we'll focus on the spinal cord, and sometimes we treat the brain. So I'm going to go through a couple of these treatments step by step along that chain of events so that you can see how doctors think about these things. And I'm going to finish with the coolest part of all, which is what happens up in the brain. I am a pain physician, and I spend almost all of my time on spine. So all of the examples you are going to see are about the spine. It is a personal deficit, and I apologize to you, but that's really the only thing I think about. So the specific examples I'm giving you are spine, but essentially the analogy works for any other part of the body. We start by thinking about the way body parts heal. So this is a picture of a spine. This is kind of a side view, and you can see the bones stacked one on top of the other. And then right here, you can see there's a little extra bit of this organ, which is a disc, and it's pushing back into a nerve that's right here. Now, the problem is at the disc, but the person feels it in the nerve. This condition heals itself almost all the time. You get a disc bulge, you get a disc herniation, and the body heals it up. This person had pain that was getting worse over a period of 2 years. It feels like this: pain that starts in the back or buttock area and shoots down the leg. And it's terrible. And many of us have this. This is one of the leading causes of disability in the world. So because she wasn't healing herself, it was on us to try to help her. And we do it by putting something in this space right here in the hopes of taking pressure off of that nerve. This is what it looks like on the inside of the spine after we've removed some ligaments. You can see this big thing right here with blood vessels on it. That is the nerve that is trapped behind this lump of white stuff, which does not belong in this space. That's the herniated disc. So Brian, you're not the only one who gets to show disgusting things. I just need to figure out how to hit the play button here. All right, there we go. So the important things here are that we push the nerve out of the way so it does not get injured. There we go. And we expose that area of the disc, which is pushing on the nerve. And we open up that space and start pulling it out. So this right here is the disc material. It's tough, it's fibrous, it's springy. It's why you can twist to the left and to the right. And when it's pushing on a nerve, it's very, very painful. So we remove it. And what it looks like when we take it out of the body is on the next part, but you can see how much it struggles. It's a lot of pressure, a lot of volume, and this is what it looks like when we take it out. Kind of gross. I want to compare the left side and the right side here. On the left side, that was the pre-picture, and on the right side, that's the post-picture. So on the left, you can see the piece of disc pushing the nerve up, and on the right side, you can see the hole there. The body could not heal that one on the left, and the body can heal the one on the right. But you notice that we made a hole where there wasn't a hole before. This is an injury the body heals better than that other one. That's why doctors do this. Now, this is potentially dangerous, right? There's a big, important nerve sitting right on top of that. And there are other important nerves in there. We do this because 8 out of 10 times, it's a successful treatment. People heal up with some rehabilitation, they learn some exercises, and they go on to take care of themselves 8 out of 10 times. Very successful. But some people don't respond like we'd want them to, like they want to. They're not able to go back to work and spend time with their family and play with their grandkids. Another big issue in the human body is arthritis. This is good old-fashioned arthritis that you get as you age. It's where the joints wear down. It's where the cartilage wears out. And we have no cure for this. We have no real way to reverse it. We haven't figured it out yet, but everybody gets it. Sometimes it hurts, sometimes it doesn't. Since we can't go in and pull a piece of it out and expect people to feel better, the treatments that we have are the next step up the chain. Sometimes the way that we treat this arthritis, especially in the spine, is to injure the nerves that connect these joints to the spinal cord. So on the last step, we helped a body part heal. And on this step, we say, look, we can't heal it. We know we can't heal it, so what's the next best thing to do? And we just interrupt the signal from that joint to the spinal cord. So instead of healing, people just don't feel it. They walk around, they live their lives as if they didn't have arthritis, which is interesting to think about. Because it's not a healing treatment, it's not a curative treatment, it's not like what we want medicine to be, but it's still an effective way to use our understanding of anatomy and our understanding of how these things work in the body to help people's lives get better. This can be an amazing treatment. It can turn pain all the way off for some people if they have pain from these joints. And it can last for months or years with very low risk. Very interesting. But there are still people who have pain that we can't treat. So then the next step in the chain is a spinal cord. Now this is a picture of a spine. This is an X-ray. And we started off in the body part, and then we made our way to the nerves, and now we go to the spinal cord. There are times when we don't have a condition we can treat or cure, where we don't have a nerve that we can try to interrupt, and we still want to try to treat pain. And from what Aaron told us earlier, we know of a way to do that. We can affect the spinal cord. So this spine has a couple of needles stuck in it, and through those needles, we put wires. And those black dots on the wires are little places where electricity comes out. We can use electricity to change the signal on the inside of the spinal cord and turn pain down. This is something that can work even for conditions we don't have other kinds of treatments or understanding for, like complex regional pain syndrome. It can work after people have had operations in the back that didn't help them out. It can work for other strange conditions that I won't get into today. And it's remarkably effective for what it is. It can help more than half of people decrease their pain by more than 50%. And for some people, about a third of people you treat with this, you can actually get their pain score to be kind of where the rest of us live all the time, which is maybe 2 or 3. That's not bad. And there are other ways we might be able to affect the spinal cord as well. Aaron was talking about the glial cells. There might be ways to deliver medications directly to the spinal cord where that first set of hijacking cells and signals starts to happen. And there might be ways that we haven't yet figured out that we can use the cells in the spinal cord to really help people's pain. We're just scratching the surface at this part of the technology. These are treatments that we use to try to get a really bad pain down to an okay pain, something that we can go back to work with, something we can play with our grandkids, get up out of an Adirondack chair, for example. But sometimes even our best treatments don't work. Sometimes the healing works well, but the procedure itself caused an injury that can't be healed. Sometimes there's a condition that we just haven't figured out a good medical treatment for. We don't understand it enough, or it's too dangerous to do something. Sometimes everything looks just fine and we can't figure out what it is that's still hurting. And this is where I'm going to step back into what Aaron and Dr. Brian, was talking about. They were talking about these times when things go wrong, they go haywire, we can't figure out what's going on. We just don't have a good way to help people come through the other side. We have a treatment for this. And this is the part I told you I'm really excited about. This is the part that happens in the brain. You recognize this from Aaron's talk. And these are the parts of your brain that help you make decisions, help you find enjoyment in life, help you do the stuff that you think is important. And this is the part of the brain that makes you feel threatened and helps you understand how you contextualize the things around you. These like deep parts in here are the parts that help you like understand your deepest emotions. And these parts up here put a meaning to it, and then you get to act on it. And this is actually how we help people who have not gotten better after 9 surgeries, who are miserable, their family hates them, they hate themselves, they don't get out of bed, they hurt all the time, they take too much medication, and they can't find a way out of it. We've known about this kind of treatment for decades. It works for people that it doesn't, that no other treatment has been found to work for. And it depends on simple things. It sounds simple when I say it, it's not actually simple. Physical movement. People who have severe pain have developed kinesiophobia, like Brian was talking about. The kinesiophobia is actually the same thing that Aaron was talking about before. You drop the kettle and you don't pick it back up again until your hand is healed. You're afraid to do it because it hurt. But sometimes when the pain lasts too long not doing that, it doesn't help you heal anymore. So we help people take little steps over time to bring more movement back into their life. It takes a very special kind of patient therapist to do this. And it takes this special kind of patient to want to try. But if we do this over time, it can decrease that fear of movement, increase people's ability to do things they never thought they could do again. The other major part of this kind of program is pain psychology. Now, psychology isn't something that you do when you're crazy, in this case. It's because living life with this much pain is hard. Because your family hates you, because you hate yourself, because you're not doing the things that you love, because you're depressed. And it also helps you figure out what it is that you love in life and what's worth pursuing. These are the things we spend 100 hours on in order to help people get better. So this is not a simple treatment. It's not easy. It takes a lot of time and a lot of commitment to make the changes that are required for the brain to start changing pain. There's another couple of interesting things here. First of all, what Brian was talking about with catastrophization is one of the main things that psychologists talk about. It really has to do with understanding that the world really doesn't end when you hurt worse, and some things are worth hurting worse for. When you combine these two things together, you start affecting the brain in a different way. Aaron talked about hyperalgesia. That's when normally non-painful signals are perceived as pain. When you put these things together, those signals can start to decrease so that normal pain feels like normal pain. And movement and touch and all the things that we shouldn't experience as pain start to go down on that scale so they can feel normal again. The other interesting thing about these two things together is that that's the most effective way to treat depression. If you just do pain psychology in people with chronic pain without the exercise, depression doesn't get as much better. Physical movement helps the brain. So this takes weeks of time. It takes a ton of effort. And it's hard for me to talk about this in a way that sounds plausible, because if it was just movement and talking to somebody, surely everybody would be doing it. But it is a profound treatment with amazing effect for some people. And I'm going to show you in someone's own words what it is to go through this. But first, I'm going to mention one mind-blowing thing. Most of the time, when people participate in these programs, they stop taking their pain medication. So even though they're involved in one of these programs, they stop using their pain medication. This is a program to help people with pain. But I didn't mention any pain treatments in that program, did I? I didn't say they come in and they get their pain treatment. It's a program that is focused on function, and it's a program that's focused on living a better life. And when we take the pain medication away, it often simplifies life, and it can decrease the side effects that Brian was talking about. And people still tell us that their pain goes down. I'm going to let you hear it from this guy. He went from 200 milligrams of morphine in a day down to 0 by the end of the treatment program. And as soon as I get the mouse to work again, there we go. This is what he has to say about what
it's been, to put it very, very directly, a miracle for me. I had got to the place where I didn't want to get out of bed. I had severe pain, lack of mobility. I walked with either a walker or a cane just to try to function, but I didn't get out of bed very often. I did pretty much when I had to and did what I had to do and just suffered the consequences, whatever they were. But over the last 6 weeks, this program's helped me to gain my life back. I kind of feel like my pain ruled my life, and now I'm in charge of my life again. We may not ever be pain-free, but we can learn methodologies to try to deal with that pain. It's been a miracle. It's the best thing that's happened in 9 years to me and my family. It saved my life. And my family's, they've been through so much.
That's the kind of thing that can happen when people learn to find the movement, find their values, and work toward it. So you'll notice that he did not say that his pain went away. You'll notice that he did not say that he was at a 1.5 and that's a miracle. What he said is that my pain used to rule my life and now it doesn't. So I'm coming back to this because you remember how frustrated I was at this pain scale. I'm pretty sure this just isn't a good pain scale. What we really need to do is put a couple more things right alongside it, like a suffering scale and a limitation scale. Because for some people, when we don't have an effective medical treatment or a surgery or procedure or some medication that we can use, they might not be able to heal up, and we might not ever be able to budge that pain score directly. But what we can do is teach them skills they can use to decrease their emotional suffering. We can teach them ways to decrease their physical limitations. And when these improve, you heard that your brain can start to take its effect and the pain can go down some. This is extraordinary because the healing hasn't happened and we haven't interrupted words, but the brain is changing. What's going on in the body and what's going on in the spinal cord and what's going on inside so that life is better and pain is decreased. Now I'm coming to the very end of my presentation here. I don't have 100 hours to share with you. But I do have just a couple of words that you can take with you to understand how this kind of program pulls together the things that we need in our lives to be more whole and more full and allow our dazzling brain to help us with pain. So I'm going to give you a couple of minutes with these 3 words that I'm going to show you so that we can hopefully change your brain tonight. The first is function. You've heard me say that a lot. We need gentle movement in our lives. We need to be able to move the body. And very small changes that accumulate over time can add up to big changes in your ability to do important things. One of the important things with trying to bring more movement into your life is not to push too hard or too fast, but take little steps at a time, allow the body to desensitize, and see what happens a year from now. Another important thing about function is that we spend a lot of time thinking about exercises, getting the body strong. And that's actually not probably the best way to do it. Focusing on activities that are important to us, that's the most important function we can have. The second thing I want to talk to you about is fulfillment. There is nothing that's worth doing unless you really care about what happens. So these kinds of programs, they work because people say, I really need to do this for my grandkid. Or I really need to do this because I have a heart of service and I want to share that. Or they say, I really need to do this because I got to go back to work. finding something that is fulfilling allows us to have the motivation to go into these hard, difficult, and painful actions and activities over and over again, because we know it's the right thing to do, and we know it's good. The final thing and the hardest thing is forgiveness. We spend a lot of our lives thinking about how we fit in with other people, about how we do our work, about how we are able to support our family. And people who have chronic pain are constantly guilty about what they are not able to do. And there's a lot of anger between people who have chronic pain and their families and their friends in both directions. So it's important for people to forgive each other about these kinds of angry situations, these kind of guilt, this kind of feeling of not being good enough or adequate enough. And then the most important part is actually forgiving yourself for maybe not being the person you thought you should be, and instead making the most of what you have. So now that I've told you these three things, which are the principles of this kind of program, I want to remind you that this all comes from the brain. It all comes from that front part of the brain that Aaron talked to us about. This is how you can use your dazzling brain to help you live a better life with pain.
Thank you, everybody. Can you hear me?
Is this mine?
You can hear me. Great. Thank you. Wasn't that terrific? That was amazing. I'd really like to thank Aaron, thank Brian, thank Evan. That was just amazing 3 talks. I got to hear the dress rehearsal yesterday, and so I was the lucky one that got to hear it twice, and it was like, I'd like to hear it a 3rd time too. But before I go on, I'd really, he doesn't know I'm going to say this, but I'd really like to thank Bill Shuttleworth, the chair of neurosciences, because he really was the master behind organizing this and setting this up. Would you stand up for me, Bill? And then you've always got to thank someone's partner, and she's also the Meg Shuttleworth. Could you stand up too? Meg Shuttleworth has her PhD in neurosciences, and she's also one of the best behavioral therapists in our UNM Pain Center and does an amazing, amazing job. So I started the Pain Center in 2011, and we treat approximately 9,000 patients per year. It's one of the largest pain centers in the Southwest. We're very proud of it. I stepped down in just about 3 months ago, and Dr. Chari, one of our UNM clinical psychologists, is now kind of running the program. But these 3 amazing clinicians are part of the program, and Dr. Rivers oversees the physical medicine program. But the UNM Pain Center is run by a huge diverse set of clinicians, from interventional pain doctors, chiropractors, pharmacists, addiction psychiatrists, physical therapists, myofascial therapists like Dr. Shelley, who do trigger point injections. Meg Shuttleworth does counseling and does a mindfulness-based stress reduction, does biofeedback. We have a whole host of clinicians that see patients in kind of a co-located fashion. And it's just a wealth of a program for our city, for our state. You have to be referred by your primary care provider to get in, but we're just so proud and so happy to be representing here tonight. I think that there's a really delicate balance in chronic pain in this country. Chronic pain is probably the biggest problem we have in America right now. I think when I turned around, when Amanda was talking about how many people in this country have chronic pain? I think everyone either rose their hand if they had chronic pain or a loved one has chronic pain. And over 100 million Americans suffer from chronic pain, according to the 2011 Institute of Medicine report. Chronic pain is probably the leading cause of every medical condition known. It trumps diabetes, all vascular diseases combined, meaning heart disease, diabetes, and stroke, in terms of the number of Americans suffering from this condition. And then we have, so not only the public health condition of undertreatment of chronic pain, but then also right now we also have the public health epidemic, as you know, of unintentional opiate overdose deaths, which really started here in our backyard of New Mexico. In 2005, New Mexico led the country in unintentional opiate overdose deaths. And right now I'm proud to say that in 2018, we've dropped to number 18 in the country. We've done an amazing job. And it's because of community efforts like you're coming to this program and learning about things like chronic pain and what you can do and best practices, chronic pain treatment, that have really allowed us to drop from number 1 to number 18 in the country. We haven't necessarily dropped in terms of the number of deaths to opiate overdose, but other states have gone way up. We've done remarkable things like community outreach in terms of naloxone. We have now mandated continuing medical education for every clinician in this state for pain and opiate substance use, regardless if you're a physician, if you're a nurse practitioner, if you're a physician assistant, if you're a pharmacist, if you're a nurse midwife, you have to take several hours every year in pain and opiate substance use disorder. And then we are getting more and more clinicians trained in being able to provide buprenorphine, which is one of the best treatments for opiate substance use disorder. So there's a real delicate balance in treatment of chronic pain and unintentional opiate overdose deaths. What we're going to do now is take your questions, get these experts here to handle all of your questions. So I think Bill Shuttleworth and Pari Noskin, who also has been an amazing behind-the-scenes effort in this. Okay. So this goes to Evan. Evan, is there a name for the physical movement or pain psychology therapy? What would you kind of call this practice?
Is this on? Okay. It goes by several names. The one that I call it is functional restoration because it really focuses on people's emotional and physical functioning, and it's trying to get them back closer to where they need to be. But there are other ones too. Some people call them chronic pain rehabilitation programs. Sometimes you can find them under the name like interdisciplinary pain treatment programs.
Great. Okay. Now, I'm kind of smirking because I had a suspicion that this question was going to pop up. And I think I might ask one or two of you to answer, and don't all jump up at once. How does cannabis work to reduce pain? Brian or Aaron, would you like to take a shot at it?
So I can tell you from a kind of a preclinical perspective that we think that because there are different kinds of receptors in our body, those are specialized molecules on cells, including on our pain neurons, and they are activated by cannabis. And some of those receptors are known to calm down the glia. And so we think one possibility, although it's not the only mechanism that we think of, may be that it's not only acting on neurons to quiet the neurons down, but it is in addition acting on those glial cells I was telling you about to calm them down.
Thanks, Aaron. Brian, would you like to talk a little bit about cannabidiol and how that might be perhaps more effective than the THC component?
Right. First, I want to say Erin has a remarkable way of working glial cells into a lot of her sentences, and I'm in awe. I think cannabis is an example of something that we were talking about tonight. It affects the brain, but we have receptors throughout the body as well. So it's the brain, but it's other parts of the body. And Joanna referred to the two best known active constituents in cannabis, THC and cannabidiol. There are many others, probably. And so I think we're still at the beginning of understanding how this plant works, which has many, many active substances in it. And so some people respond in terms of chronic pain to the cannabidiol-heavy strains, which tend to affect the body with many exceptions. But many of my patients get more benefit when they have a product that is a combination of THC, which affects the mind, and the cannabidiol, which affects the body. And so we're working through this together. I've learned most of what I know about it from my patients, because we didn't have a cannabis course in my medical school. And I'm not sure they ever will at the University of North Carolina. But and then I just want to say, like everything, this is limited. Not everyone responds the way they're supposed to, as it were. And that's just because we're all different. And whether you're talking about cannabis or muscle relaxers or opioids, you have to look at the individual, and people respond in different ways to these things. So let's not see cannabis as this panacea, this thing that's going to solve everyone's problem.
Terrific. Thanks, Brian. A very close colleague of mine who runs, who's one of the leading migraine and headache doctors at UCLA, Dr. Andrew Charles, told me, and as you know, recreational cannabis is now legal in California. He said, Joanna, he said, if cannabis was effective for migraines, there would be no migraines in California. So he told me, or there'll be no cervicogenic etiology of headaches, meaning no headaches that are caused by neck pain either. So we know that cannabis is not the pure 100% cure for a lot of sources of pain, but it can be helpful. Here's another question. I will ask. I think I'll ask I'll ask Brian. Brian, as you might have heard, he said he's a muscle doctor, and another name for that is myofascial pain. And something that I just might brag on Brian is that recently, with Brian and another one of our colleagues, Ben Dates, have started a myofascial institute at our pain center, and so they're teaching about every 2-3 months. We're teaching clinicians how to do trigger point injections and teaching about the body, teaching chiropractors and physical therapists also how to move. And so this question for Brian is, what is referred pain? And also, how do you think that it will also assist physical therapists to manage, to ease chronic muscle pain? So can you talk a little bit, Brian, about what is referred pain in terms of your practice?
Pain's when you go to the doctor and your doctor refers you to somebody else. I'm done. The first part of that question is easier, I think. Referred pain refers to pain being experienced in a different place than where it starts. So, and this is not just with muscles and nerves. We often see people with pancreatic pain talk about pain between their shoulder blades. That's a referred pain. The pancreas is here, but the pain is experienced back here. One of the most commonly affected muscles that we see is the trapezius muscle. And there's a spot here that I bet some of you have that can send pain to the back of the neck. But people will come in and say they hurt here, but it's really coming from here. So that's the concept of referred pain. And it is bedeviling. And when I have my own referred pain, I need someone else to help me find the source. Because you can really think it's in the elbow when it's really coming from here, et cetera. The second part of the question I don't really understand. It sounded like it was about how physical therapists might learn how to do this. I'd say it's the opposite. I learn a lot from physical therapists, and they're the masters of that domain. Yeah.
Actually, I think, I don't have anything to add for the second part. That's commonly a part of their practice, but I'd like to just take 2 sentences to talk about how awesome referred pain is, because it is a side effect of the way the body was organized as an embryo developing in a mommy's belly. So when we were first formed, we were just these little chunks of flesh stuck together, and those things eventually kind of grew into arms and legs and everything. And so we are still connected in the same way that we were back in the embryo. We just can't see it organized the same way because now we have fingers and like faces. And so when you mash on some of these areas, you perceive it in that whole area that's connected by the way that you developed as an embryo. Isn't that cool? I think it's awesome. Okay, anyway, that's all I needed to add.
Question for you, Erin. You mentioned glial cells in your talk, as Brian mentioned, and we all learned so much from you, Erin, as being kind of the bad actor in terms of causing the cascade of pain. What causes glial cells in the central nervous system to become activated?
Well, that's a great question. And what we know now is that when there is injury to our body, for example, our nerves that I was talking about, those nerves start to release things that not only communicate to that other neuron in the spinal cord, but it also spills over into the surrounding glial cells. And it turns out these glial cells hug the space between where neurons communicate between each other. So these glia can listen to neurons talking to each other, and then they can respond. And what happens is they respond by themselves releasing factors that also further activate those neurons. So it creates this feed-forward effect of hyper-excitability of those neurons and glia exciting neurons and so on.
Thanks, Erin. I have a question for Evan. This says, it appears that, for instance, what you said on your talk, that the clinicians are not using so much the 1 to 10 number chart anymore, or maybe they are, but that they're beginning to use more functional scales in some clinics, in some pain clinics. Can you describe what functions they're asking patients about now?
Yeah, absolutely. So first of all, I don't think that anybody's throwing away the pain scale. I don't think that it will ever go away. I do think that the amount that we weight it is changing. And so the pain scale itself still tells us really important information. But when we give people the opportunity to tell us how their sleep is, how their physical activity is, how their emotional activity is, how their social functioning with people around them is, that's when we start to get a better idea of how they're actually doing in the world with their pain. And so there are several really high quality validated scales that bring in these concepts: pain interference, physical function, emotional function, depression, sleep, and some that put them all into one scale, like the brief pain inventory.
There's one last question. I'm going to just take the bully pulpit, as Brian used to say when we worked on the Echo Pain team together. And this says, please say something about migraine headaches. I might just tell you that there's been huge advances in migraine headaches beginning in 2018. There's now 3, soon to be 4 new FDA-approved medications, preventive medications for migraine headaches. All of them, 3 of them are used on for a monthly basis for both episodic and chronic migraine headaches. And they are, as far as I can tell, I've been prescribing 2 of them quite readily, and they are working very, very well. Aimovig and Anjovi, and they are subcutaneous injections that the patients can take by themselves. They work by blocking calcitonin gene-related peptide, which is a similar mechanism that the triptans, how the triptans work, and the triptans are used as abortive therapy. So if you are a migrainer and you respond to triptans, meaning that the triptans have been effective for you, you might benefit from these new preventive agents. Your primary care provider or your neurologist should be able to prescribe them for you. That's the latest and greatest new medications for migraines. Botox still is effective, and I think Bill is calling it.
Thank you. Let's thank our panelists and moderator very, very much.